Hi, I'm Dr. Ron Berkman, and today we'll be covering the postpartum period and be discussing a number of common problems that occur during the puerperium. With the prior video, we did discuss the major physiologic changes, but by reading the chapter, looking at both videos, and participating in the classroom session, you should be able to basically understand all three of the items listed here, though this particular video will deal with some of the common complications and problems of the puerperium, as well as discuss some of their management. If we look at what concerns postpartum women have in the first 2 to 9 months after delivery, certainly the need for social support leads the list. And if you think about it, for many of these patients are sleep deprived, have all the challenges of feedings and taking care of a newborn, and layered on this oftentimes is all the other activities they had before they had the baby. So again, you can see why there is this feeling of a substantial need for social support. In addition, since many women breastfeed, a substantial number, about 25% almost, will have some issues with breastfeeding during the course of their postpartum period. Many also feel that they've had inadequate education about newborn care. This is probably most dominant among women with their first baby, or it may be someone who's not had a child for several years and has forgotten some of the do's and don'ts of newborn care. Also, a small number of women will want help with postpartum depression. Some perceive that they need to stay in the hospital longer, and some also have concerns about loss of medical coverage. When you actually look at the morbidity that occurs in the first 8 weeks postpartum, fatigue certainly leads the list, and again, I think we all understand that from the standpoint of the requirements of care of a newborn. But following this are breast problems, followed by anemia, backache, hemorrhoids, headache, blues, and then constipation, and then breakdown of either a cesarean section incision or even episiotomy, as well as vaginal discharge. At least 80% of women, or 87% of women will report at least one of these symptoms, and about 3% of women in the postpartum period will be hospitalized due to bleeding, infection, or hypertension. The first problem that we'll discuss is lactational mastitis. And this particular disorder has been estimated to occur in between 2 and 10% of breastfeeding women. And as we discussed briefly in the last video, the postpartum blues oftentimes are a precursor. Potential risk factors include a history of mastitis in a prior pregnancy, as opposed to women who've never had history of lactational mastitis. Poor milk drainage, such that again ducts will become clogged, and again bacteria will be allowed to grow as the milk becomes stagnant. Cracked nipples, which allow bacteria to enter into the ducts, and even the use of antifungal cream on the nipples has been associated with some increased risk of lactational mastitis. Feeding problems also are associated with this particular disorder. Certainly partial blockage of the milk duct with the stagnant milk, which allows bacteria to grow, oversupply of milk. Infrequent feedings can increase the likelihood of this. Nipple excoriation or cracking certainly allows entry of bacteria. Rapid weaning, the mother or baby becoming ill, stress, malnutrition, all have been associated with this particular disorder. Clinical presentation is as follows. Initially, usually you will see engorgement, and this occurs because of poor milk drainage, perhaps related to nipple trauma, which again causes the nipple to swell and leads to compression ultimately of one or more milk ducts. If symptoms persist beyond 12 to 24 hours of the engorgement of this type, the condition of infective lactational mastitis develops, since again breast milk contains bacteria. So again, you can see it's a rapidly evolving condition. Infective lactational mastitis usually presents as a firm, red, painful, swollen area of one breast associated with fever, and also very frequently with systemic complaints such as myalgia, chills, malaise, and flu-like symptoms. so rapidly progressing once it gets going. And here we see a picture of a woman with lactational mastitis. You can see the area of redness on the lateral side of her right breast. And again, if you were to palpate this, this would be very tender to touch. The microbiology. Staph aureus certainly is the most common organism, including MRSA Staph aureus. In fact, MRSA has been cultured in 44% of women hospitalized with mastitis, and about 2/3 of those who are hospitalized with an abscess, so a very common finding. In addition, you can see group A and B strep, E. coli, Bacteroides, Corynebacterium species, as well as coagulation negative staph. And again, these are all from cultures of breast milk. Differential diagnosis is not that long, and again, it's relatively easy to make this diagnosis. With, for example, severe engorgement, usually this is a bilateral condition, and usually there are no systemic symptoms. With an abscess, usually you will have the progression of symptoms that we just discussed and have a tender fluctuant area. And again, if there's any question at all, an ultrasound can be utilized to make the diagnosis and facilitate guided drainage. A plugged duct usually results in a tender lump and without any of the systemic symptoms. A galactocele is really a cystic fluid collection that occurs after a plugged duct and usually is non-tender and also without systemic symptoms. And finally, one other consideration is inflammatory breast cancer, and this would be in someone where the mastitis doesn't seem to resolve, and one sees skin that's thickened with edema, erythema, and peau d'orange appearance, and probably in an older individual as well. So if we look here, this is a picture of a woman with an abscess. You can see that the area around the nipple certainly are swollen, and this also would be very tender to touch should you palpate it. And then we see this area that looks a little bit like what we just last saw, but you can see that the skin appears thickened. There is this peau d'orange sort of appearance to it, and this is a woman with inflammatory breast cancer. Clinical management, certainly there is the use of nonsteroidals and cold compresses for discomfort. Women should continue emptying the breasts, and in general, nursing is not contraindicated. Antibiotics certainly should be administered with persistent symptoms, particularly fairly early on with the onset of fever, or if the area of discomfort and so forth is lasting beyond 12 to 24 hours. If there's no improvement after 48 to 72 hours on antibiotics, an ultrasound to rule out an abscess certainly is indicated. The antibiotics that are utilized, if you have a non-severe presentation where it's just beginning to present, certainly the use of dicloxacillin or cephalexin are two drugs that are utilized, or erythromycin if a patient is beta-lactam sensitive. If there's a concern for MRSA, the use of trimethoprim sulfamethoxazole is indicated, or clindamycin. And finally, if you have a patient with severe symptoms who's relatively unstable, the erythema is progressing, high fever, there's concern for overall sepsis, vancomycin administered on a patient weight basis with a dose not to exceed 200 milligrams is utilized. In general, if a patient shows rapid improvement, treatment for 5 to 7 days is in order. Otherwise, treatment should occur for somewhere between 10 and 14 days overall. The next disorder we'll talk about is postpartum depression. According to the CDC, approximately 11 to 20% of women in the postpartum period have some form of depression. This is not too dissimilar to what the overall prevalence is in the general population, but this certainly is a time period where being depressed can certainly be challenging, given that one also has to provide care to a newborn. Major risk factors include depression that occurred during the pregnancy or anxiety during the pregnancy, stressful events during pregnancy. This could be in terms of living issues with a significant other or other issues of that sort. a newborn problem such as a preterm baby or an infant that requires NICU care, this all will increase the risk. If a patient has low levels of social support to deal with some of the events we just discussed, as well as the newborn, this also increases the risk. Certainly someone with prior history is at increased risk, and someone with breastfeeding problems also appears to be at increased risk for postpartum depression. Screening, a variety of forms are available. I think the most widely utilized, and it has been tested heavily in women in pregnancy as well as postpartum, is the Edinburgh Postnatal Depression Scale. This is a screening tool that should be administered several times during the pregnancy itself, fairly early in the postpartum period, and then perhaps once or twice more, say at 4 or 6 weeks postpartum, since again the likelihood of picking up individuals with this particular disorder is increased. From the standpoint of treatment, certainly if a psychiatrist is available, you can rely on cognitive behavioral therapy, or can have groups sessions where there's peer counseling, but in a high percentage of cases, patients will require antidepressants. This is a algorithm for providing antidepressants. If you note up in the upper left-hand corner, this group called MCPAP for moms has a whole host of materials available to anyone who wants to go on their website. So you just sort of put down MCPAP for moms, and this will get you to the website. And there are a variety of toolkits, including this treatment algorithm as well as screening tools that are very useful. This is an organization that is in Massachusetts and actually facilitates access to psychiatrists, even for telephone counseling. Unfortunately, it is only for Massachusetts and is not available yet in most other states. But as we follow this algorithm, you can find that if the patient is already on antidepressants and is doing well on what they are taking, then you basically would leave them on it. If they're not doing well, then you would go to another medication. If someone has never been on and they're not resolving, certainly the first line treatment is sertraline, though other SSRI options include fluoxetine, citalopram, and escitalopram, all of which again have the dosage as listed below. And again, the toolkits that this organization provides discusses how again all this should be administered. Most of these patients require frequent follow-up every 1 to 2 weeks, or even more frequent depending on the degree of the depression. The next issue that we'll talk about is hemorrhoids. Certainly this is exceedingly prevalent in the third trimester as well as the immediate postpartum period, being a problem that affects 25 to 35% of women in terms of being symptomatic. There are two types. There are the internal hemorrhoids, which occur above the dentate line as shown here, and external hemorrhoids, which occur below. Hemorrhoids which are internal, again above the dentate line for the most part, basically are insensitive to treatments, or certainly less sensitive, whereas external hemorrhoids tend to be more problematic from that standpoint. If you look at additional classifications, and here's this of internal hemorrhoids, you can see you go from a grade 1, where the hemorrhoid basically remains above the dentate line, all the way down to where there is a grossly evident prolapse that's not reducible, with a lot of inflammatory changes and bleeding and so forth. And these sorts of hemorrhoids, if they persist, are the types of hemorrhoids that require some type of surgical treatment. Conservative treatment, however, works for the vast majority of individuals, and a lot of it revolves around diet and lifestyle changes. Certainly there is strong evidence from randomized trials that increasing fiber intake improves the symptoms of hemorrhoidal bleeding as well as mild prolapse. And again, things like Metamucil, which contain psyllium and so forth, are certainly supplements that patients can take. Also, obviously, for postpartum as well as pregnant women, oftentimes they are on iron, which tends to make them constipated. And the sooner that the anemia, if they have it, is treated and they can be off these medications, the better off they will be from the standpoint of not having to deal with as much with hemorrhoids. In addition, patients should refrain from straining or lingering on the toilet. Regular physical exercise reduces the chances of hemorrhoids. Obviously, avoiding medications that cause constipation, such as iron, and limiting the intake of fatty foods and alcohol, all are approaches that will reduce the risk of constipation. A popular myth is that eating spicy food increases the risk of hemorrhoids, but in at least one controlled study, it had no effect, certainly on the symptoms of hemorrhoids. Medications certainly can be used. Topical ointments that include analgesics, such as a mixed hydrocortisone lidocaine creams, are effective for relieving acute pain. Topical steroids such as hydrocortisone alone can be utilized. Again, with use of steroids, the treatment should be limited to approximately a week to avoid some of the side effects, including thinning of the mucosa. Vasoactive drugs such as phenylephrine, which is in preparation H, do provide also temporary relief of bleeding or pain on defecation and appear to be well tolerated. And of course, the old standby sitz baths certainly can be utilized, and it's certainly useful when there are acute flare-ups in order to reduce inflammation and edema and relax the sphincter musculature. Keep in mind that once in a while, though, you also need to refer patients with hemorrhoids for colonoscopies. Certainly if you have an older individual who's in her 40s who has rectal bleeding, and even though you suspect it's hemorrhoids, in general they should be referred for the possibility of a colonoscopy because the risk of malignancy starts being more problematic once you reach the age of 40. In addition, patients with hemorrhoids who have the following, regardless of age, such as significant anemia that persists, bleeding that is atypical of hemorrhoids, change in bowel patterns, personal history of colorectal polyps, or family histories of inflammatory bowel disease or colorectal cancer, these patients also need to be referred for possible colonoscopy. The last item that we'll discuss is perineal pain and dyspareunia. Certainly, perineal pain and dyspareunia, as well as low libido, is a fairly common problem after childbirth. However, if it persists well beyond, let's say, the first several months of the postpartum period, it can have some long-term changes and difficulties, and certainly professional assistance would be imperative. And it's common to have a certain degree of perineal pain, and it's reported in up to 10% of women 1 year after vaginal delivery, and a lot of times scar tissue at the introitus from episiotomy is a common cause. Some degree of postpartum dyspareunia has been reported in up to around half of patients, even as late as 6 to 7 weeks after delivery, with 30% reporting some discomfort 3 months later, and even 17% at 6 months. The risk factors that increase the risk of perineal pain and dyspareunia include infection, operative vaginal delivery with potential tears, 3rd and 4th degree lacerations, wound separation of an episiotomy or laceration, that is a breakdown afterwards, pelvic organ prolapse, and breastfeeding. Certainly vaginal atrophy associated with breastfeeding due to the hypoestrogenic state, which is due to, again, prolactin levels being high, results in the dyspareunia due to inadequate lubrication and the lack of rule folds. Other treatment options, certainly you need to have a communication between the patient and their significant other, and again discussing this, and again pointing out that this is part of the overall physiologic changes postpartum, and also to recognize that a lot of times the lack of libido is related to fatigue and even lack of time. Certainly one should consult with a certified therapist if the problem persists, particularly if it is becoming a problem for the relationship. If you note that there's some granulation tissue, let's say in an area where perhaps some stitches were or there was a tear, certainly ablating this is in order. Using water-based lubricants for sexual relations certainly is a time-proven approach. And for those patients that appear to have a very tender area in the detritus, perhaps due to tenting of some of the tissue, where a crown stitch was done, let's say for an episiotomy, oftentimes you can revise this particular area with a perineoplasty, which will certainly relieve the discomfort and resolve the dyspareunia that the patient is having. So this ends the second video, and hopefully by going through this you will understand how to manage some of the problems that occur in the postpartum period. But obviously if you look at the chapters in the textbook that deal with the postpartum period, as well as attend the upcoming session, we'll be covering other issues as well as the ones covered here today.